Good evening, everyone, and welcome to the Integrative Community Practitioner Forum. I'm Robert Davis, and I'm a member of the steering committee of UVM Integrative Health. I'm an acupuncturist and a researcher, and I'm lucky enough to be a longtime friend and colleague of our speaker tonight. UVM, or the Integrative Community Practitioner Forum, is hosted by UVM Integrative Health, and that is a joint initiative by the University of Vermont Medical Center, the UVM College of Nursing and Health Sciences, and the Larner College of Medicine at UVM. This talk is part of an interprofessional series on non-drug methods that can help to manage pain. Before I introduce the speaker, I have a couple of housekeeping items for everyone. Number one is we now offer continuing education credits, so you can find the series listed in My Credits. Number two, Kara has parking passes for the garage. Kara is standing up back there. Right, so if you need a parking pass, grab one at the end. Our next forum is going to be on May 10th, and we'll cover the topic of art and healing. If you didn't register on your way in, please do so on your way out so that we can send you an evaluation form and a link to the site where you can claim your CE or CME credit, and also a link to the recorded talk. So this evening, it's my pleasure to introduce Helene Langevin. Dr. Langevin is certainly a respected leader in the field of integrative medicine, and part of what makes integrative medicine great is the integration of both the objective and the subjective when caring for patients. So I thought it would be appropriate to introduce Helene by including some of both with regards to her objective credentials and background, and also her subjective credentials and background, that is, the effects that she has had on those she has worked with. So objectively, we know that Helene is the director of the Osher Center for Integrative Medicine at Harvard Medical School and the Brigham and Women's Hospital. She received her MD degree from McGill University. She did a postdoc research fellowship in neurochemistry at the MRC Neurochemical Pharmacology Unit in Cambridge, England. She did a residency in internal medicine and a fellowship in endocrinology and metabolism at Johns Hopkins Hospital. She's currently a professor in residence of medicine at Harvard Medical School, Brigham and Women's Hospital, and she's a visiting professor of neurology, orthopedics, and rehab at the Larner College of Medicine here at UVM. She's also the principal investigator of 2 NIH-funded studies investigating the role of connective tissue in low back pain and the mechanisms of manual and movement-based therapies. Her previous studies in humans and animals have shown that mechanical tissue stimulation during both tissue stretch and acupuncture causes dynamic cellular responses in connective tissue. So you've heard some of her objective credentials. Now for some of her subjective credentials. I want to tell you from personal experience how Helene affects the people she works with. Helene has impacted me personally through her example and her mentorship. She's helped me to appreciate what it means to be a scientist, to think clearly, to have integrity, to challenge conventional thinking when necessary, but to never overstate findings or draw unsupported conclusions. I've worked with Helene in group settings, think tanks, boards, projects that involve teams of experts, and what I've observed subjectively is that people love to work with Helene because she elevates the discussion. She has a sharp intellect, but she never uses it to bully. She uses it to respectfully promote clear thinking and constructive action. Her curiosity and creativity inspires others, but unlike some visionaries who inspire us but have difficulty creating a roadmap, Helene also excels at details and at getting things done. I've observed Helene's curiosity in action. It's very infectious. She'll get curious about something new and something that maybe has never been measured. And instead of saying, there's no way to measure that, she adapts tools for the job or she invents new ones to get the job done. So objectively and subjectively, Helene is qualified, very well qualified, to speak to us this evening. Helene, welcome home, and thanks for coming to speak to us tonight.
Thank you. So I'm talking in here. Thank you, Robert. I want to make sure this is turned on. Can you hear me now? No different. Oh, yeah. So thank you for this lovely introduction, and it's very sweet for me to be here. Obviously, I was at UVM for 20 years. Still am here, although I'm most of the time in Boston now, but it's always nice to come back. It's like being home. So I'm going to talk a little bit about some of the work that we're doing in the lab about those four things. So connective tissue, stretching, inflammation, and musculoskeletal pain. I'm going to try to bring that together in this talk today. But before that, I want to talk a little bit about integrative medicine because, and not just integrative medicine, but integrative health in general. What is integrative, right? What is it that we're integrating when we do integrative medicine? And we usually think about it in terms of, well, we have conventional medicine, right? And then we have these alternative therapies, and we're trying to bring them together and integrate into whole patient care. But there's another kind of integration that we try to do. And I think we're trying to heal with integrative medicine a problem that has been since almost the foundation, the beginning of modern medicine really, is where at the beginning of the 20th century, right, when we started discovering about all these wonderful physiological systems that were in the body, cardiovascular system, right, respiratory system, digestive system, and people really started getting into these systems as systems, and then, but the problem is that most of medicine and also a lot of physiology, right, understanding how the body works, has been cut up that way. People study these systems one at a time. And that has kind of bled into the entire organization of medical schools, right? Hospitals, specialties. So you have the cardiology department for the heart and the lungs, the blood vessels, and then the pulmonary for the lungs. And then that has also determined how science happens, right? And so really we think of the body in a very disconnected way. And so that's not only, there are examples where we understand the relationship between these systems. For example, we know that the nervous system, for example, interacts with the cardiovascular system, right? Because we understand how the autonomic nervous system helps us control, for example, blood pressure and things like that. But there's a lot of places, a lot of systems where we still don't really have too much of a clue as to how connected they are. Just give you an example. If you were to ask somebody who does yoga, for example, is it possible that how you breathe, your respiratory system, influences your gut? I think most people would say, yeah. But if you look at research on both respiratory and digestive, and if you do PubMed search on these two terms, you find almost nothing. And that's really because, gastrointestinal and respiratory are two different groups of people. They don't often interact and meet. But that's beginning to change. We are starting to understand now connections between things that we didn't used to. For example, the immune system, right, and the nervous system. We didn't used to understand how your thoughts, your emotions can influence your immune responses, but now we do. There's a whole field now of neuroimmunology. Some people even call it psychoneuroimmunology. And that field is relatively recent. When I was in medical school, that didn't exist. But now we're beginning to understand that there are relationships. So what I want to talk about is obviously what we want to arrive at an integrated view, right, of the body, right, as a whole. Not just the body, but the mind, too. So the two systems or groups of systems that I want to draw attention to in this talk are the immune system and what I call the musculoskeletal system, which here there's kind of broken into two, muscular and skeletal, but usually musculoskeletal systems when we think about it as a unit. So what about the musculoskeletal system and the immune system? Well, The musculoskeletal system, we usually think about it as, what is it, right? Bones, muscles, and ligaments, tendons, things like that, right? That allow your body to move. That's why we think about it. And we are beginning to understand a lot more, however, about the musculoskeletal system. We used to think that when you contract your muscle, right, it pulls on your tendon, and that's what makes your bone move. But we now are beginning to understand that that's actually not the case. It's not as simple as that. There's an entire system around the muscles called connective tissue that connects all the muscles together. And we now know that a lot of the forces that a muscle exerts does not go directly into the tendon. It actually goes sideways into the connective tissue and pulls, and then it gets transmitted to the muscles next to it. And so there's like this entire sort of force or field that develops around a muscle. It's a lot more complicated. So we now understand that the connective tissue, which is called that white stuff around the muscles, is a very important part of the musculoskeletal system, which we didn't used to understand before. Same thing with the immune system. We used to think that the immune system was kind of a bunch of sort of cells floating around the body, right? Immune cells like neutrophils, lymphocytes, T cells, macrophages. These are your immune cells that are kind of patrolling around your body looking for trouble. Looking for infections, looking for, inflammation from their tissue damage, and to sort of, then once these immune system found something, they would go back to the lymph nodes and the spleen and report what they found, and then send, other types of cells to sort of repair. But all of this was usually thought about as kind of floating around in some sort of liquid through the body. But we know now that that's also not the case. That connective tissue, the same connective tissue that I was just talking about, that's around all your muscles and around all your bones, and the same connective tissue is actually the place where a lot of these immune responses happen. So when your immune cells are going around the blood vessels and they're sensing sort of chemical signals of that, there's a problem, in this part of the arm, there's a cut, and there's bacteria that just got in. They're going to go and they're going to get out of the blood vessels, and they're going to go where? They're going to go in connective tissue. And that's where they're going to go and do their thing. And then when it's time to go back through to the lymph nodes, they're going to enter what we call lymphatics, which are blood vessels that are, guess where? In connective tissue. All of that is happening in connective tissue. So connective tissue is essentially kind of the terrain, the theater, where a lot of the immune response happens. So, question, is it possible that your body movements, your musculoskeletal function, right, has an effect on the immune responses that are happening in the exact same place? We don't know. And so that's the question that I want to discuss today. And the immune process that I'm going to describe to discuss this is something called inflammation. So inflammation, what is that? Well, inflammation is obviously a very, very important thing. Without inflammation, we would not be able to stay alive, because inflammation is what allows us to repair wounds. If you're a lion in the jungle, right, and you have a cut or something like that, well, there needs to be a mechanism that allows not only the removing of the bacteria or things that could cause an infection, but also the cut has to heal itself. It has to, the bleeding has to stop, and the wound has to essentially stitch itself together in order for it to not stay gaping open. So inflammation is the very first phase of wound healing. Healing a wound in order to, so there are four what we call the cardinal signs of inflammation. So swelling is the first thing, because there's blood, the blood and the extracellular fluid, all these sort of edema that comes along with inflammation is how the chemicals will get from the blood into the tissues to get to the place where the infection is or the wound is. And then there's redness because of the increase in the vascular permeability and also the dilatation of the blood vessels. And so swelling, redness, and so heat, because there's increased blood flow to the area. And then I usually think about it in Latin. It's dolor, calor, rubor, and tumor, which is the swelling. So all of these things happen at the beginning of inflammation. But then, after a while, these things have to stop, right? Inflammation should not go on forever, because if it kept going, then once it has done its job, once the wound has been healed, then it needs to subside. And so what we call the resolution of inflammation is just as important as the turning it on. If you don't have the resolution, if inflammation doesn't resolve and continues, you have what we call chronic inflammation, which is where inflammatory cells continue to be drawn to the area of trouble, and then that becomes trouble in and of itself, right? And then the other consequence of chronic inflammation is that, remember, in order to heal the wound, not only does inflammation has to happen, but also something called collagen, right? It needs to be deposited in order to stitch the wound together. Otherwise, it stays open, right? So this is what we call scarring, right? Creating a scar. But when you have chronic inflammation, it's almost like you're trying to scar all the time. So you have fibrosis, you have deposition of collagen that creates this sort of fibrotic, sort of stiff mess in the tissue that continues even though it's no longer needed. So chronic inflammation and fibrosis are not good, right? So in the lab, we have decided to study the effect of movement, right, on inflammation. And in order to do that, we use a model of inflammation that causes chronic inflammation, not just acute self-limiting, but inflammation that continues. So it's a model of this. And the way we do that is we inject a substance called carrageenan. And carrageenan, I hate to tell you, but it's actually something that's in a lot of foods that we eat, a lot of like yogurt and ice cream. And we started reading labels really carefully when we started doing these experiments, because what so happens that if you inject even the tiniest amount, a couple hundred microliters of carrageenan in the subcutaneous space on the back here in this case it's a rat, and we inject this tiny little amount of carrageenan, and what happens is after it causes inflammation that lasts up to 10 weeks. So we are now using this model to look at the effect of stretching. Now, why stretching? So I had a graduate student in my lab, it was here at UVM, Sarah Corey, and she did a lot of yoga. She was really interested in yoga, and she wanted to know if the stretching that happens during yoga could have an effect on inflammation. She was really interested in that. So she noticed that when you hold an animal by the tail and you lift it, a rat or a mouse by the tail, and you gently lift it off the table, but you still allow it to grab, right, the edge of the table, what happens is spontaneously the animal will do that. It will extend its four legs forward, and their back legs, they shoot their little back legs, that they just do this on their own, and they kind of hold like that. They hold this position. And they can hold this position for quite a few minutes without complaining. Once they get, the first couple of times, they have to get used to it. And then after that, they really do it. And then you can see when they can actually hold this position for 10 minutes, if you can believe it. And they kind of just relax. And once they're tired of it, they start sort of squirming around, and then we just let them go. And so we compared this stretching to what we call a sham, where we just hold the animal out of its cage, but we don't stretch it. So we compared, she wanted to know if you train these animals and you stretch them for 10 minutes twice a day, would that have an effect on inflammation? So she noticed that when the animal, so the place on the back is right here in the middle of the back where this little bit of inflammation is. It's on top of this structure called the thoracolumbar fascia. And this is a very important structure in the back. It's got this sheet of connective tissue that connects essentially the shoulders with the hips. It's a very important part of the back. And because this tiny little bit of inflammation is sitting on top of the thoracolumbar fascia, she noticed that the rats were walking with smaller steps. They were not taking as big a step because whenever you take the step, it would kind of stretch the fascia like that. So she measured the distance of their steps, how big their steps were, and she saw that this is the sham animals. Okay, this was the distance of their interstep distance, and this was the stretch. And when she saw the stretched animals were taking bigger steps, so their gait had improved. She also looked at what they call their pain sensitivity. So if you use something like it's called a Von Frey hair, to poke on the area that has the inflammation very, very gently, and then to see if the animal will react to that. And she saw that the higher the score, it means that the more sensitive the pain is. And so here was the percent response, and she uses smaller and smaller and smaller filaments until it's barely touching. And you can see that the stretched animals have decreased pain sensitivity. It means they're less sensitive to the mechanical stimulus. And finally, she actually looked, after the experiment was finished, she euthanized the animals, and then she looked at the actual tissues, the connective tissue where the inflammation was, and she looked at the amount of macrophages, which are inflammatory cells, and she saw that they were greatly reduced compared with the non-stretched animals. So this was after 2 weeks. So stretching these animals helped them to not develop chronic inflammation as a result of this inflammatory stimulus that we knew we had given them. So this was quite an interesting observation. But you know, we weren't entirely sure what was happening to these rats, because when you hold it, first of all, there's a lot of stuff that happens when you do this. The animal, first of all, is held by the tail. So there's a certain amount of traction, right, on their spine. The other thing is that it's a little bit, I mean, even though we don't believe these animals are terribly stressed because they don't vocalize, they don't struggle when they do it, but nevertheless, we thought there might be some sort amount of stress, you know, that the animal is experiencing during that this animal does not have as much stress. So we thought, well, maybe this is some kind of just non-specific stress response that's going on. Because, you know, when you have stress, like, for example, not stress is necessarily bad. Even if you go like running, for example, you have a release of stress hormones, right? That's a normal thing. And some hormones, for example, glucocorticoids, are very potent anti-inflammatory. So we thought, well, maybe this is simply an activation of the pituitary adrenal axis. So that's possible. So we thought, okay, well, let's look at this and see and try to do an experiment to sort that out. So we decided to compare this, what we call active stretching, where the animal is stretching actively, like I described before, to passive stretching, where you actually anesthetize the animal, and then we stretched the animal passively the same amount that the animal was stretching spontaneously, about 25% of the increase in length. And then we compared that to simply anesthesia without stretching. So you see in these two animals here, that controls for the stress, the traction, all of that. And also here, the other thing that happens here is the animal is using some muscle activity, right, in order to engage the muscles and hold this position. So we didn't know, you know, all of these components are just out of the picture with the passive stretching. And so we wanted to know, is passive stretching still work? And you can see here, when you compare anesthesia only without stretch to passive stretching, into active stretching, it's almost as good. I mean, there's no statistically significant difference between these two conditions. They're both better than anesthesia only. So it looks like passive stretching is doing something. And so what we were wondering is, okay, does this have simply to do with stretching the tissues? And the tissues, of course, that we're very interested in is the connective tissue. And so that's what we decided to pursue. So, okay, well, I talked earlier, well, so what could be the mechanism of this, right? So the I talked about how inflammation needs to turn off and resolve in order for it to not become chronic. So quite recently, actually, there were a whole new class of molecules that are called specialized pro-resolving mediators. And these are molecules that are derived from fatty acids, more specifically the omega-3 fatty acids or N3 fatty acids that are in the fish oil. These are dietary fatty acids that we have to eat. We don't make them ourselves. And so from these dietary fatty acids, specifically two different types, EPA and DHA. I'm not going to tell you the whole long names because I can't pronounce them. But so these mediators are secreted, are produced at the very beginning of inflammation, normally. Anytime you have a little, injury or cut or something like that, this happens. So at the very beginning, within 3 to 4 hours, at the beginning of inflammation, it's already programming itself to stop. And what these pro-resolving mediators do is they take this whole inflammatory response and then they gradually shift it towards what we call resolution and basically cleanup. So you have different classes of inflammatory cells. More specifically, macrophages, you have the M1 and then the M2 macrophages. The M1 macrophages are the big sort of battling macrophages that kill everything in sight. And then the M2 macrophages come up and then they sort of clean up the mess and prepare the tissues for basically going back to normal. And these resolution, it shifts the M1 to the M2. And they do a lot of other things. They'll also promote cytokines, different types, you've heard of cytokines, different types of cytokines that are more pro-inflammatory, and then he's going to shift towards a pro-resolving type of population. But if that doesn't happen right, for whatever reason, if the pro-inflammatory cytokines end up dominating, then this doesn't happen. And then you get the end result, which is failed resolution, chronic inflammation, and fibrosis. So we wondered, is it possible that in our stretched rats, that what you're doing is you're actually shifting more towards here? Is it possible that the stretching is activating these pro-resolution mechanisms? So we decided to test that. Because we knew that this resolution mechanism, the release of these pro-resolving mediators occurs really, really early on. Remember that first experiment I was telling you about? We went 2 weeks, right? We were stretching these rats for 2 weeks. Well, we thought, well, let's shorten the duration. Let's look in the first 48 hours. Let's see if what we see. Is it possible that we during acute inflammation, that stretching still does something? So that's the first thing we did. We looked at the same experiment, same carrageenan inflammation in the back, same stretching, but this time only 48 hours. So the animals are only stretched 4 times, 10 minutes each time. And we looked at the thickness of the inflammatory lesion. This time we used an ultrasound machine to measure how thick the lesion was. We also look at the total inflammatory cell count and neutrophil count. These are the most important cells in acute inflammation. Neutrophils, polymorphonuclear phagocytes, these are cells that are really the first line of cells that come in at the beginning of inflammation. And you can see they're reduced by almost half. So the stretching, even though it was not stretched very many times, had a profound effect on the inflammatory response. It really dampened it down. Then we said, okay, let's compare the effect of stretching to the effect of injecting these pro-resolving mediators. And the one that we decided to look at is called Resolvin. You see the Resolvin D2, which is one of those fatty acid products, right? And so we injected the Resolvin without stretching, and we compared that to stretching without the Resolvin injection. And you can see that the two results are almost the same. So stretching had almost the same effect as injecting the Resolvin. Then we said, okay, is the stretched tissue producing extra Resolvin? So here this time we measured Resolvin D1 because there happened to be an assay kit that was commercially available. But since then, we've repeated that experiment with Resolvin D2. And you can see that it's increased in the stretching. And then at the same time, we looked at the inflammatory mediators, and you see they're decreased. And if you look at the ratio of the Resolvin, remember I was saying it's the ratio of the two that matters, it's greatly increased. So it looks like that stretching promotes the shift towards resolution and away from inflammation, all right? So this is exciting because it's a natural mechanism, right, which is enhanced by doing something like stretching, which is kind of also a pretty natural thing to do, right? It's not a drug, it's non-pharmacological, yet it's kind of boosting a natural sort of healing response that's going on. So the one thing we wondered, okay, well, but this Resolvin, we found it in the tissues, we measured it in the tissues, but could it be coming from somewhere else? Maybe this Resolvin is being made, who knows, in the brain or some other place right now. We didn't know where is this Resolvin being made. So we decided to do an experiment, which we called ex vivo. We take a piece of tissue from an animal after euthanasia, and then we take the tissue out, and then we decide to stretch the piece of tissue, but in a dish. So there's no cardiovascular system, right? There's no blood circulation in there. There's no nervous system. It's just a piece of connective tissue. That's it. And you see at the top, I can't quite point to it, but you see this little piece at the top, there's like this little window cut out in it. So we cut out the little skin, and then there's still a piece of connective tissue left underneath the skin. And we put some neutrophils. These are the cells that are the cells that accumulate during inflammation. Now, during inflammation, a very important thing is that the neutrophils they follow a signal, and then they travel to where the inflammation is. And we put a substance at the bottom of the bath there that calls the neutrophil. It's called a chemoattractant. And we wanted to know, if you stretch the tissue, is there a different amount of neutrophils that go through the tissue or not? What we found is that there was. So here we're looking at the neutrophil cell count in the bottom bath underneath. And you can see there's less neutrophils in the stretched tissue than the non-stretched tissue, which means that stretching slowed down the movement of the neutrophils. And actually, movement of neutrophils is a very, very important part of the inflammation response. We then measured the resolvins in the bath to see if the tissue was producing resolvins. And on average, it was more than in the non-stretched. So what it looked like is that this resolution was happening right in the connective tissue. This was not a systemic response. This was not something that was happening in the whole animal. This is something that's happening right there at the tissue that's being stretched. It looks like some kind of mechanical effect. So, okay, so why is this important? Well, there's a lot of things that happened when you have an injury besides inflammation. I talked about scarring, and scarring is the end result, right, of inflammation. But sometimes that's the result that actually can cause problems. So here I've given an example of this. This is a piece of tissue you can see at the top. Sorry, I can't point to it, but I'll try to use this pointer, but it wasn't working all that great. Can you see this little tiny red dot? So here's the skin of the animal. This is a piece from a mouse. This red thing is the subcutaneous muscle. That's how the mouse can wrinkle its skin. We don't have that. Here's the back muscle. And here you see these two blue lines. These are two layers of connective tissue. We call them fascia. These are layers in the back. And in between these two layers, you see this white stuff? That's loose connective tissue. These are layers that allow the layers of the fascia are dense connective tissue. They're more like sheets. And the loose connective tissue allows these sheets to have some independent motion. Otherwise, if we didn't have this loose connective tissue, we'd be all in one block like this. It's what allows, tissues to sort of slide past one another. But if we do an injury, like if we injure, we have this experimental model where we essentially just disconnect and cut between those two layers, and then we let them heal. And what happens is after a week or two, actually I think it's 2 weeks, the tissues just glued together. And you can see here, post-injury, not only have these layers increased in thickness, but they're actually stuck together, they're fused. That's called an adhesion. And so when two layers are adhered, they don't have any more independent movement. So you have a loss of mobility in those layers. That's a problem. And we became interested in that because we became very interested in what the structure that I was talking about earlier, the thoracolumbar fascia. This is a layer, very important layer in the back that has many, it has a structure that has many layers to it. So it has layers that correspond to the aponeuroses of all of these back muscles. So the top layer is the latissimus dorsi. It kind of connects, fans down the back like this, connects the shoulders all the way down to the iliac crest. Underneath of that, you have the internal external obliques, which are the muscles of around the abdominal cavity. And then underneath of that, you have the erector spinae muscles that are right on the side of the spine. And so you can see that the top and bottom layers, the latissimus dorsi and the erector spinae, they have a kind of a north-south, right, direction of pull, top-bottom. Whereas the obliques, they have a more of a lateral direction of pull. So it would make sense that these layers would have some independent motion. It wouldn't all be glued together, and that's actually the case. So here is an ultrasound picture of the thoracolumbar fascia here in a human. So you can see here, this is a longitudinal, so the ultrasound probe is right next to the back, 2 centimeters lateral to the spine, at the level of the L2-3 vertebrae. So here is the white stuff here, that's the thoracolumbar fascia, and you can measure it. And you can see that this is a healthy person, and you can see that this fascia has a certain thickness to it that you can measure. And we noticed that we were doing a study for some other reason, and we noticed that in some people, the thoracolumbar fascia looked a little thicker, and then some people it looked like this. It looked like really disorganized, and so we wondered, is it possible that there's some kind of pathology in this fascia that could be either maybe some inflammation, maybe even some fibrosis, and we wonder if it might have something to do with patients having back pain. So a lot of the people we were looking at had back pain. So we decided to do a study of that. And we measured the thickness and also what we call the echogenicity, how many echoes are generated by the ultrasound when we do an image. And we first looked at the whole distance between the skin here and the body and the muscle. And so that's what you see here. So you can see here, the people with back pain in general, on average, are higher than the people without back pain. And then we looked at 2 different parts. First, the subcutaneous tissue, right, between the skin and the fascia. You see there's no difference in the subcutaneous tissue. All of this difference here was due to the perimuscular fascia. This is the thoracolumbar fascia around the muscles. And so you can see that this is increased in people with back pain up here compared with the controls, right? And so this increased by about 20%. So it's not a big increase, but it was significant statistically. And so we wonder, well, okay, if people who have back pain have slight increase in how thick their layers are, could that be because there's some chronic fibrosis perhaps going on in these layers? So one thing, remember I was telling you about all these different layers? Well, these layers, we can actually measure how they move using ultrasound. And what we do is it's a dynamic ultrasound. And we're actually able to measure how these layers are moving in one relation to another, corresponding to all these different muscles that I was telling you about earlier. So the way we do that is we have people lie down on this motorized table where their head is here and their feet are back down there. And the table flexes like this, back and forth slowly. And the person's, the hinge point of the table is right at their people's hips. And essentially they're flexing their body back and forth like that, but passively. And during that time, we record an ultrasound movie with the ultrasound probe in exactly the same place that we had it before when we were doing the picture, okay? And so I'm going to play you what it looks like for a normal person. So what I want you to focus on is this layer here, the thoracolumbar fascia. You see there's 3 layers to it. And you should look and see about whether these layers are moving together or separately. And this is a normal subject without back pain. And I hope you can appreciate that these layers are not all moving at the same time. You have some layers that are moving faster than others, and even at some point, layers moving in the opposite direction. Can you see that? So that's what we call differential movement. Or another way to talk about it, we can call it shear strain. Shear strain is when two layers are moving past one another like that. Now I'm going to play you an example of a movie of somebody who has back pain. And I hope you can see it. There's not quite as much movement there. It looks like the layers, you can't quite tell if the layers are stuck together or perhaps the muscles that these layers are attached to are pulling. We don't know which is which, but there's less movement for sure. And so we are able to measure that, and we tested 116 subjects, and we looked on average at how much shear strain there was, and we saw that for the people who have back pain, there's less, about 25% less than those without back pain. So that suggests to us that there's some reduction in movement. So we didn't know what it was for. And our idea, actually I'm going to skip these two slides, I'm going to go straight to here. We were wondering if, because we know, right, that stretching is good and it decreases inflammation and fibrosis, well, what about not stretching? Right? If you prevent an animal from stretching, could you induce this kind of pathology? Because one way we think about it is that if you have, say you injure your back, you strain your back, or even a small injury, you're not going to want to move because it hurts to move. And therefore, you're going to avoid stretching. And maybe the lack of movement is part of the problem here. So we wanted to experimentally induce a reduction in movement. So we did that by preventing the animal from extending their leg backwards. And we connected the one strap around the leg. And the animal actually gets used to this. They learn to make smaller steps, but they are still able to function. It's just that they cannot extend their leg back. And we wanted to know if combining movement restriction with a tiny, tiny little injury of the fascia, where we did the same kind of thing I showed you before, where you disconnect the layers between the two layers of fascia and then you let it heal. And we wanted to know if you had a combination of injury plus movement restriction, would that look like somebody with back pain? And so we used the same ultrasound measurement methods that we used in the humans. We first had to make sure that the animals were actually growing at the same rate. And so we also saw that even if you take the hobble off, the animals are still taking smaller steps compared with the controls. So it did affect their gait. And then when we looked at the thickness, we used the exact same measurement that we used in the humans. You saw that so the hobble by itself didn't do it. But the injury, this is where we take the ultrasound image on the other side of the injury. So this is not the injury itself. This is the response of the thoracolumbar fascia on the other side of the body, which I think is very interesting. So the thoracolumbar fascia became thicker on the other side. And then when you combine the hobble plus the injury, you also have an increase. But where it got really interesting is with the shear strain. So the hobble by itself reduced the shear strain, again on the other side of the body. The injury also did, but then the hobble plus the injury had a real cumulative effect. That really did it. And so this looked a lot like our back pain results. So the question then is, well, if this is the model, right, if this is the model that you have a combination of inflammation, perhaps because of an initial injury or sprain, and then you at the same time reduce the mobility, and then you introduce perhaps some fear, right? Fear of movement, because is that kind of create this kind of vicious circle? And how would you interrupt that? Would stretching, if you did it consciously, if you tried to stretch the tissues, even if it might hurt a little bit, would you be still able to reduce the inflammation, right? So we wanted to know would decreased movement, would movement restore this whole situation back to normal? So stretching a pig is not as easy as stretching a rat, because you cannot suspend them. So we devised this contraption here where we suspended the pig, and they actually are able to relax. Once they're used to this, they can hold in their, this is this kind of sling. And we decided to stretch their hips, and I'm going to tell you right from the beginning, that was not a good, it was not, if we had knew what we know now when we had planned this experiment, we would not have done it this way. But I'm just going to show you, because science doesn't always work the way you want. So we decided, because we were restricting the mobility of the hip, we thought we were going to stretch the hip. So, okay, and we first looked at their, they were hobbled. All these pigs had hobble for 8 weeks, and then we took the hobbles off, and then we stretched them every day for a month. And we wanted to know, does this restore their gait back to normal? And does it restore their shear strain mobility of their fascia back to normal? Well, if you look at, this is the gait, velocity, how fast they walk. This is the control. This is injury alone. This is hobble plus injury. So you see their gait is reduced. This is the remove hobble. See, now these animals are now able to walk. They are allowed to walk. And this is the stretched. And you can see the stretched animal did not get better. So something about this stretching did not do well. And then when we did we looked at the shear strain, you can see that the injury plus hobble, this is the group that remained hobble, was still reduced at 12 weeks. Removing the hobble improved it a little bit, but stretching did not. So something about this stretching was not right. And now, in retrospect, we understand, I think, why. Is that we didn't stretch the right, remember we were looking at the thoracolumbar fascia. And the thoracolumbar fascia, what stretches the lumbar thoracolumbar is movement of the shoulder, right? If you try, you should all try this. Put your hands up. You can see how much it stretches your back. Stretching your hip is not going to do it. Stretching both together would have been a lot smarter. If we had known that, I think that's what we would have done. So instead of just stretching the back, the hip here, we should have stretched both the shoulder and the hip, and that's what we're going to do next. So if you compare, see this movement here with the rat and this movement with the pig, we really should have extended that. But we were really thinking that way because when we started, I'll get to that question in a minute. So if we had known what we knew about the rats when we started the pig experiment, I think we would have done it differently, but we're going to get there. So what I hope I showed so far, I mean, in this talk, is that movement for sure, and the musculoskeletal system and the immune system there's a way that you can influence the immune system with body movements. I mean, I think that's very clear in our minds right now. The million-dollar question is, what type of movement, right? How much moving? How much stretching? How often? What amplitude? What duration? And we're just at the beginning of this. We're just starting to investigate this. So it's going to be a long time before we can actually determine we're not recommending that anybody does these types of movement. These are experiments that this is not patient care, right, obviously. But the exciting thing is we were able to already identify a mechanism by which this happens. This whole inflammation resolution mechanism is something that I think is very interesting because it is a natural response of the body which we are able to augment. So more to follow this, but right now this is kind of where we are. So I want to acknowledge, obviously, all the people, both at the University of Vermont, where a lot of this work was done, and the Osher Center Connective Tissue Lab at the Brigham and Women's Hospital, and of course funding from the NIH, National Center for Complementary and Integrative Medicine, that has funded this work. Thank you. Okay, so you had a question here already?
My question is, the research you did on the pig, was it a passive stretch?
Yeah.
So it wasn't mechanical with another?
It was passive. So, yeah. So, very good question. So, when I said I had this slide, well, why did it work in the rats and it didn't work in the pigs? Well, there's a million reasons for that, right? Very different things we did. First of all, different animals. Maybe, and the anatomy of the pig is very different from the anatomy of the rat. Even if we could reproduce this exact same stretching in the pig, it might not work because the connective tissue layers in the pig are a lot more attached. The pigs are a lot more like us. That's why it's a very, very important model. It's very possible that what we do in rats does not translate right to humans. So that's why we wanted to do it in the pigs. But you're right. What you're pointing out, the stretching method was not the same. It was passive, whereas the rat is active. But remember when I showed that slide of the passive stretching of the rat under anesthesia? That still worked. So that's why we kind of thought, well, maybe passive stretching would work. So what we're going to do now with the pigs is we're actually just starting this experiment, I think, next week. We're going to put the pig in the same kind of sling, but we're going to now lower the sling to the ground and let them touch the ground with their front feet. And we're going to gently lift the back feet, but let them bear some of the weight. Because a pig is too heavy. We wouldn't be able to lift them completely. But we were going to now have the pig participate a little bit in the stretching. That's what we're going to try. And we'll see if that works any better. If it does, then we probably going to want to compare the two. We might end up having to do the experiment where we anesthetize the pig and stretch it under anesthesia, just like we did with the rat. I mean, we're going to have to try different ways. But we're really interested in this question because I think it's a very important one. Do you have to engage the muscles in order to stretch the connective tissue, or is just stretching the connective tissue by itself? So, yeah.
Right, because the pig was not anesthetized, right?
No.
So the pig, even though you think you're passively, isn't it going to feel that sense of being stretched and then grab?
It may.
Like that?
Oh, you mean
I'm sure
on the one that's yeah, we don't know how they're going to respond.
there's going to be a resistance.
Yeah, are they going to participate or are they going to fight the movement? We don't know. And well, same thing with the rat though. The rat is actively engaged. It's holding on.
Unless it was anesthetized.
Yeah, but it worked both ways. But with the pigs, they have these little hooves, right? So they won't be able to grab. So we're still not sure if this is going to work. You know, yeah.
Another quick understanding was that both of the animals, you were actually extending them, whereas that table you showed with the human, they were flexing. So those are two different movements for stretching two different.
Well, the table, we're using the flexing not for stretching. We're only doing it for measuring yeah. That table is only for measurement of the amount of stretching. It's not for treating. No.
Oh, right, okay.
Right.
Because I was just saying
It's not bending this way. No. And you know, the funny thing, I get this question a lot because a lot of people say, well, here's your thoracolumbar fascia, right? So your animals are extending, they're not flexing. But think about it. If you just try this, raise your arm. That's how you're going to stretch that. You know, it's not by bending. If you bend, you're just bending. Your thoracolumbar fascia is not doing a whole lot. But when you do this, it's really stretching. So it's counterintuitive. And we fell into that trap at the beginning of the experiment too. We didn't think about it. Yeah.
Definition of acute inflammation in time frame versus chronic inflammation towards fibrosis.
Okay. Acute inflammation, 48 hours. By 72 hours, you're already starting to transition over to chronic. And then anything more than 72 hours, that's no longer acute. You know, and so the definition is, you know, it's a little, there's like this kind of gray zone. But by the time you start seeing macrophages that persist, especially M1 macrophages that persist, it's okay to have some M2 macrophages because that's what they're supposed to do. They're supposed to come and clean up, and that takes a couple of days. But if your M1 macrophage population persists like 4 or 5 days, a week, 2 weeks, that's chronic. So, yeah, that's the... Yeah?
Yeah, I would like to understand better with humans with low back pain, what we were discussing, lesions or wounding that cause the...
Yeah, we don't know. All we have is ultrasound pictures. So obviously in a human, you cannot go and take a piece of that fascia and look at it under the microscope. That would be, you know, bad. So we don't know. We really do not know the pathology. That's why we need the pig model. Because in the pig, not only can you take the ultrasound picture like you do in the humans, but you can also look at the fascia under the microscope. What I didn't show you is that when we did look at it in the microscope, we didn't see anything. We did not see a lot of inflammation. We did not see a lot of scarring and fibrosis. Partly, I think, is because the model was quite mild. And quantifying fibrosis in histological pictures is very, very hard. So we're still not sure at the moment what is the pathology that underlies this. We think it's just, the main thing that we think happens is that you got this sort of, well, literally adhesions. There's remodeling of the collagen so that it is no longer distinct layers, that the layers actually just become, you know, connective. They just get stuck together, you know, for lack of a fancy word. Yeah. Oh, no. No. Yeah, so, right. I mean, if you have a surgical wound, right, it'll take more than 48 hours to heal that wound. But the acute phase of inflammation, hopefully, well, first of all, when you have surgery, you have stitches, which helps, right, to get the wound back together. But if all goes well, the same process will take place. You'll have first, at the very first 48 hours, you see an influx of neutrophils, all the acute inflammatory cells, a lot of redness, a lot of swelling. But then, you know, gradually, pretty quickly, by, you know, 3, 4, 5 days, some of that redness and swelling should have gone away, and now you're in the process of repair. That repair phase lasts longer than 48 hours, clearly. I mean, it takes, you know, how long does it take for you for, like, say you have even a small cut, you know, if you put a Band-Aid on the cut, you know, the first couple of days, if you take the Band-Aid off, the cut is going to reopen, right? But after a while, if you take the Band-Aid off, the cut stays together. If you pulled on it, it might reopen. But, you know, if you wait maybe 4, 5, 6 days, it's no longer open anymore. It's meshed. That's the scarring that takes place. So it takes a while, you know. But, you know, how long does it take before you can take your stitches off? It depends on the size of the wound. Yeah, same thing. I mean, it's a very similar process. It has to do with recruitment of both inflammatory cells at the beginning, and then the cells that I didn't talk about, but are very, very important, are fibroblasts. The fibroblasts are the cells that actually manufacture the connective tissue. They make the collagen. So the fibroblasts are recruited to the area, and then they start making collagen like crazy, like mad. And then they plaster the wound with a whole bunch of collagen, and then the collagen becomes cross-linked and it sticks together, and that's what allows the wound to stay closed. And then there's another type of cell, which I also didn't talk about. They're called myofibroblasts. Those are kind of interesting cells because they are fibroblasts that have then transformed themselves into like little mini smooth muscle cells. And what they do is they help close the wound. They pull the edges of the wound together. And this is interesting. I was talking about before, a lion in the jungle. Before, you know, if you don't have stitches to keep your wound closed, you need a mechanism to close the wound, right? And that's the myofibroblasts. They actually pull and close the wound. But myofibroblasts can also turn on you. If you have chronic inflammation and you have fibrosis that's ongoing, you can have an increase in myofibroblasts in the tissues that last longer, and that's actually not a good thing. So, you know, these very important mechanisms that are life-saving can also become a problem if they don't turn off. Yeah?
How richly innervated is the fascia? Is it different in different parts of the body?
Oh, that's a great question. So, yeah, the fascia, up until recently, we did not know a whole lot about this. However, there was some observation, like, for example, people who did muscle biopsies. You know, if you do a muscle biopsy and you insert a fairly large needle through a muscle, it hurts only when you go through the fascia around the muscle. Once you're through the fascia, you're into the muscle, you can move your needle around. People don't feel anything. So a lot of the sensory innervation of the muscle is actually in the fascia. But up until recently, that was not very well characterized. We didn't really know what kind of nerve endings are in there. But we now know that there's quite a rich innervation of the fascia. There are nociceptors. There's also all kinds of what we call silent nociceptors. These are mechanoreceptors that respond to stretching, but only in the presence of inflammation. If there's no inflammation, they don't fire. They only fire when there's inflammation around. So that's also an important thing. Yeah. Okay. Thank you.